Again, we will be listening to Dr. Mohammad Tahir, and I think his presentation will be also much beneficial for us. He will be talking about LVAD in the management of cardiac cases. Dr. Tahir, please.
So I've been given an interesting task of LVAD, left ventricular assist device. I just wanted to ask, is any experience anybody has in this part of the world of LVAD or not? Okay, so it would be basically a talk about refractory heart failure and what do you do in these people who are basically still alive, and there are some criterias which are there which will decide whether they need a mechanical circulatory device which will help in making their aids to daily living a little bit better than what it is. So that's where we start. I must admit that I do not do LVADs. I have about 4 or 5 patients who have LVADs, and I have a patient who went from LVAD to have a heart transplant. So they are something which are going to be more common in those parts of the world where transplants are rare or they are difficult to get, and they will surpass the number of people, implants than the transplants would be. And it's already happening. So there we start, and so it is increasingly prevalent, the heart failure is, and what we are talking about, stage D heart failure. So the New York Heart Association classification of 1, 2, 3, and 4. So we're talking about 3A, 3B, and 4. 3B is one where they're still short of breath, but they still can walk around a little bit, but are exhausted. And 4 is basically they're bed-bound because of shortness of breath, and there are no very limited survival, and say, can't do anything. So there is a significant technological advance which has happened in the actual circulatory device, that the durability of the devices have increased. The survival has lengthened of people. In comparison to medical management and those who did get the mechanical circulatory device, their survival lengthened and the quality of life improved. But at what expense? And that is the adverse events which are related to the device therapy are still considerable. So in the United States, there are about 5.8 million people who have heart failure, varying degrees, from 1 to 4. And the estimated incidence of about 650,000 new cases a year annually. One of the reasons why there are so many people who are in heart failure and they are progressively getting worse is, number one, that the age of the population, it's progressively increasing, so you see them more. The other is that the intervention which takes place usually after coronary artery disease, myocardial infarction, and stents placements, revascularization, and associated myocardial damage, which may have happened by the time the intervention took place. So about 1 million admissions in the United States are from heart failure. And there are about 300,000 deaths which are attributed to heart failure. The cost is enormous, and it's estimated at about $40 million, or $1 billion, sorry. So it's easy to say, but billions are billions, it's a lot of money which is involved. So what is estimated is that the prevalence of heart failure is going to significantly increase, as by 2037, there would be about 10 million people, with heart failure. So coming back to what we were talking about was cardiac transplant was the best mode which was available for people who had refractory heart failure and have been treated medically and had not responded very well. And their survival rates were significantly great. At 1 year, 86% were alive and doing significantly well. And by 10 years, 46% were still alive. The problem is that you can't get donor hearts. So what do you do with people who have refractory heart failure and they have failed medical therapy? So coming back, so it's a ventricular assist device is a circulatory device that is used to partially or completely replace the function of a failing heart, whether it's the right side of the heart or the left side of the heart. So we're talking about systemic or pulmonary. It's just the same thing. It's 30 in a pie chart, which I just told you, the cost and all which is associated with heart failure. And I'm sure, you know, the Canadian cost is probably a little less because everything is, I don't want to go into that detail, but yes. So causes of heart failure, there are many. I'm not going to go into the details, but the ischemic and the non-ischemic and associated conditions, which may all result in refractory heart failure. So we did talk about the New York Heart Association classification, and that's where we are, you know, I'm in say 3B and class 4, where these circulatory devices are considered. So the whole idea behind it is, can we improve the quality of life and improve their symptoms, slow the progression, or reverse the cardiac and peripheral dysfunction and reduce mortality? So the whole idea behind all this thing is, can we achieve it? With the transplants, donor transplants becoming static in the last 10, 15 years. So that was the question. And you know, this was an interesting cartoon I saw, and I thought it would be, so if you have a horse which is diseased or you want to make it run better, you can whip him. You can unload the wagon, reduce the load on the heart. You can slow the horse. You can give beta blockers, right? You can get a new horse, transplant, right? Get a tractor, do a circulatory device, maybe help, or heal the horse. So a lot of stem cell transplantations have been used. There is a very interesting article I just read in one of the local papers, and that they have found some evidence that it may come to something in the next 10, 15 years, where you can actually grow the heart muscle cells, and they would function and improve the function of the heart. So medical therapy, we all know about it. You know, these are, you know, I mean, say being used. I would not go into that detail. Diuretics are used. Diuretics improve symptoms. They do not have any significant impact on the prognosis of the person. So we all know about the medications. Some of them have made a significant improvement in heart failure. The only two drugs which the FDA approves of using it at home is Melrenon and dobutamine. And that is for patients who have cardiomyopathy, and in spite of all the medications, they still remain in heart failure. So the first non-pharmacological therapy which came out was the resynchronization therapy, or where you had, it's also known as a BiV AICD or a defibrillator, and these patients should have fulfilled the following criteria: that the EF should be less than 35%, they should be in class 3 or 4 heart failure, and the QRS on the EKG should be greater than 120 milliseconds, and they should be on optimal medical therapy. Certainly, some patients did get benefit, but not all of them. So that's what it looks like on a chest X-ray. There is an extra lead which is placed through the coronary sinus into one of these veins, and it just improves the left and the right side of the function of the heart. So in spite of all this, if there is progression of heart failure, and that is that the renal function is deteriorating, the liver function becomes abnormal, and the pulmonary hypertension increases or becomes, so that would be one of the reasons, Mohammad said to do it. So there are two sorts of devices, the long-term ones and the short-term ones. Dr. Namat mentioned about the ECMO. It's a short-term device which is used, but we're going to talk about the long-term device, which is the LVAD. And there are certain criteria which the person should fulfill or should not have before they would be considered for having this circulatory device. It's a life-changing experience for these patients. It's a life-changing experience for the people around them. And it requires a lot of psychological support, physical support, understanding, of what it is, what's going to happen to them. And so all these things are taken into consideration before this device is offered to them. So this guy, you see this guy, you may recognize him. He was one of the person who got an LVAD, or a left ventricular assist device, and being the vice president, was fortunate enough to be transplanted and is still alive and doing well. So the two devices which are used are the HeartMate 2 and the HeartWare. So these are continuous flow devices. That means that there is a pump there, and this pump is continuously taking blood from the left side of the heart and actually putting it into the aorta. So this is what it looks like, and that's the a cannula which is put in the left ventricle. So it takes the blood from there. This is a pump. It's a continuous pump, and it dumps the blood up through the through this cannula into the aorta. So basically, it has bypassed a failing heart. It has other components to it. There is this the connecting unit, or the basic thing, and there is this line which is going there. That is the drive line. This is where the electrical power comes through. And then there are two batteries, which are there. One is always a secondary one, because if the first one fails, there is always power there, to continue to run this pump. And that's the way, I'm going to say, that's the basic mechanism of it. So these people have no pulse. So if you measure their pulse, you may not feel it. It doesn't mean that something is terribly wrong. It's just that the way, because the pulsatility is not there. It's a continuous flow pump. So this is something which decides the pump speed, and this is something which tells you how quickly this pump is rotating. It measures the voltage, the pump flow, and the pulsatility index. So they're typically pulseless. The blood pressure is either measured by a Doppler or an arterial line. They are afterload sensitive. It means if there is any problems in pushing the blood forward, the pump is going to slow down and will cause symptoms. They are preload sensitive as well, because if there isn't enough coming in, there isn't enough which can be pushed forward. And anticoagulation, very important, to keep their blood thin, because they are at increased risk of strokes. With it, there is an increased risk of bleeding, and this, to balance this, is something which up till today has remained very elusive. So these are the complications which normally have. You can have an inflow cannula which can obstruct, it can kink. The rotor or the pump, it can have thrombosis, it will fail. The battery will dysfunction, it cannot push the pump. The controller malfunction, the driveline infection, and the outflow graft. So all these things are very important, for this to maintain this mechanical circulatory device, and these are potential complications which are there. The one which I'm going to discuss with you, which in the emergency room normally people will, or the ER physician would do, is strokes, bleeding, and heart failure. So bleeding is still a bigger problem. Infection still remains a bigger problem. Pump thrombosis is something which is still seen, but it's not that common. But when it happens, it would require another operation and removal of these things. Right heart failure, once the left ventricle is unloaded, the right heart fails. So you have to be very careful, when you do all these things. And this remains one of the biggest problems. If the blood is too thin, you get an hemorrhagic stroke. If the blood is not too thin, you get a thrombotic stroke. So you are it's in a very difficult situation. And these are balanced, So I thought that this Churchill's saying was something which was interesting, that however beautiful the strategy is, you should occasionally look at the results. So, and this holds very true with the mechanical circulatory device. So this is what it is. This is something very significant. Those who had LVAD or a mechanical circulatory device placed, so destination therapy simply means that they will not have a transplant. This is their destination therapy, and this is what it is. There's another thing which is known as a bridge to transplant. So this was destination therapy, and 63% of patients were still alive at 24 months with medical management. In spite of all the efforts and everything, only 8% was alive at 24 months. So there is a significant improvement in mortality, and there is also a significant improvement in aids to daily living in these people. So infections, major problems. You can have an immediate perioperative problem, which is normally due to sepsis and pneumonia, but after 30 days, it's the percutaneous DLI is a driveline infection, and it is something which is very significant. Some of it is related to the risk factors, obesity, nutritional status, diabetes, and how did they fix the driveline. I talked to you about the bleeding complications. It's a problem which is there. They do require antiplatelet therapy, they do require warfarin, and if it is bleeding within the 14 days of implantation, it's more related to surgery. It's also more related to which device was put in. So the hardware, the likelihood is less than it is because it requires, the heartmate requires a large pocket placed and increase the risk of it. The reason why they bleed from the GI tract is from AV malformations, which become very common once there is no pulsatility there because it's a continuous flow. The AV malformations in the small intestine are a significant problem. So GI bleeding and CNS bleeding all are very significant. So anemia of unknown source remains a problem, and they require transfusions, and all these different approaches have been tried to reduce the INR to 1.5 to 2. That would reduce the bleeding, but would increase the thrombotic complications. And as I said, neurological events remain one of the most dreaded complications of this therapy. So, aortic insufficiency. One of the problems as the blood is pushed out from the, taken out from the left and dumped into the aorta, shear stress and onto the aortic wall cause dilatation of the aortic root and results in aortic insufficiency. This makes the pump inefficient. And it's one of the great problems which are still there, and they worsen the heart failure. Right ventricular failure after the placement of an LVAD becomes a much more serious complication, and that requires intensive medical therapy and oxygen delivery, inotropic support, vasodilators are all needed. But the interesting thing is that whether it's bridge to transplant or it's destination therapy, a significant proportion of these patients are still alive and doing well in spite of all these problems in 24 months. Obviously, there is a cost. And so this is an interesting slide. This is pre-implant. Not much could be done. They had extreme problems, but by 12 months, they could do a lot more than what they could before the device was placed. I don't have time, but there are these short-term things which are available for PCIs and all those things which are also VADs. And I think I'm out of time. So I just want to go through them. So the management of advanced heart failure is a dynamic process that requires frequent re-evaluation. Timing of LVAD is critical, and LVADs for destination therapy have been shown to improve mortality rates and quality of life. And there are short-term VADs available as well for emergent situations. And I think thank you.